Welcome, everyone. My name is Jana von Hehn. I'm the Chief Scientific Officer at the Rett Syndrome Research Trust. I'm very happy to welcome you all today to our webinar entitled An Update from the New Rett Digital Natural History Study, where we'll cover how your children's medical records have created a decades-long study in months. So our agenda for today, I'll go ahead and introduce our guest speakers. I'll give you a quick overview of utilizing untapped resources to support research, which will be the background for why we were doing this study in the first place. Then we'll learn about what a digital natural history study is and why it's important. And then we will get to see the results from the preliminary analyses from the digital natural history study. And then we'll close with a question and answer session. So I'm very excited to be joined today by Monica Coenraads, who is the CEO of RSRT. She's joining us today in her capacity as a parent in the digital natural history study. I'm also joined by Drs. Cary Fu and Bernhard Suter, who are our clinical leads on the Rett Syndrome Global Registry and the digital natural history study. Dr. Fu is the medical director of the Rett Clinic at Vanderbilt University Medical Center. He is a pediatric epileptologist, and Dr. Suter is a pediatric neurologist who's also a medical director of the Bluebird Circle Rett Center at Texas Children's Hospital. Then we're also joined today by Kristina Hone, who is the CEO of the CASC Gene Foundation. She's been our lead data scientist on the project and has been helping us analyze and visualize the data that you'll be seeing today. So before I turn it over to our speakers, I just want to give you some background on why we're doing this study in the first place. So at RSRT, our singular goal is to cure Rett syndrome. And when we stepped back and we looked at the research landscape, we realized that there were untapped resources that could be used to support research and therapeutic development that were not being tapped into. And so we realized that comprehensive medical records were sitting unused at doctors' offices. And we realized that parents had a lot of valuable information about what it's like to live with and care for an individual with Rett syndrome that was also not being captured. And so we asked ourselves, can we combine these untapped resources to expand Rett therapeutics? So we went about trying to do this. And what we decided, so the questions that we asked was, how do we access this information? And we realized we needed to create databases to collect this information and make it usable. So we needed to not only create a database, it needed to support research, care, and development in the best way. And to do that, we realized it needed to be a really high quality database. And so we worked really carefully to make sure that there was a lot of data integrity, really high quality. And we built these databases to FDA standards so that they could be used not only to support research, but they could also be used by pharmaceutical companies to support their clinical development programs as well. And then we also wanted to make sure that if we were going to build these databases, that there could be some benefits to families for participating in helping us create these resources. And so that's when we partnered with Ciitizen to create the clinical component of this effort through medical record summaries. And that's what we're going to be discussing today, the results of this initial database that we've built based on medical record summaries. And then in a future webinar, we'll also talk about the parent-reported component, which is the Rett Syndrome Global Registry, which is our attempt to capture all of this parent-reported information to be used for research as well. So as you can imagine, the medical record database, as well as the parent-reported database, are very valuable sources of information on their own. But in an ideal scenario, we would like to have parents participate in both data sets, because once we can start to combine what symptom burden is at home and quality of life is at home with what's in the medical record, then that combined data set becomes really powerful. And so what we're going to talk about today, we're just going to focus on this first part one, the clinical component of the medical record summaries in the digital natural history study. So I'm going to turn it over to Monica Coenraads to take it away.
Thank you, Jana. Okay. Hello, everyone. I'm really pleased that you're able to join us today. So let's start first by going over some basics. What is a natural history study? It's a study that collects information on a group of people to learn how the condition that they have in common develops over time. Now, in a traditional natural history study, clinicians at selected sites enroll patients and collect data into a central database. Now, our community was very fortunate to have an NIH-funded natural history study that collected data from over 1,000 individuals with Rett syndrome during a 15-year period. And this study has generated many publications and allowed us to learn a great deal about Rett syndrome. Now, as technology advances, it provides opportunities to conduct studies using novel approaches. In a digital natural history study, the patient or the parents of the patients provide a list of doctors, clinic, and hospitals that they or their children are seen at, and they provide consent for the medical records to be collected. Once the records are collected, they are anonymized, and the data that is extracted from these records using machine learning is aggregated with the data from other individuals with the same disorder. The result is a digital data set that can be used to learn about the disease and to accelerate research and therapeutic development. So let's discuss some of the key features of a digital natural history study. The most obvious feature is that it doesn't require in-person clinic visits. Now, this is important because oftentimes the patients that are seen in clinics for natural history studies are either the ones that live close to a clinic, have the economic resources to be able to travel to a clinic, and are healthy enough to go to a clinic. But that can leave a significant portion of patients who don't fall into these categories. And with a digital natural history study, all you need is an internet connection. A digital natural history study captures all of the information that is in your medical records, every doctor visit, every hospitalization, all of the medications, all of the lab work. So it's a very unbiased approach to collecting data. Importantly, it doesn't require that patients or their parents remember everything that has happened since the last in-person clinic visit, because most of us have a really difficult time doing that. And as you'll see later on in the presentation, a digital natural history study can collect years' worth of data in one fell swoop. Now, traditional and digital natural history studies each have their own pros and cons. The digital natural history study adds data from medical records, which, as Jana mentioned, has up until now gone largely untapped, to the existing data from the traditional natural history study. It's not meant to replace the natural history study, but rather to expand and enhance it. So the technology company that we're using for this digital natural history study is called Ciitizen. And it was founded by Anil Sethi in honor of his sister Tanya, who died of metastatic breast cancer. During her illness, she saw 17 oncologists and other doctors and visited 23 different institutions. And Talia and Anil realized that her doctors were making life and death decisions from limited information because her records were fragmented at many institutions, and she didn't have access to them all the time or have control over them. So Anil set out to change the situation, and he founded Ciitizen to put patients in control of their own medical records. Note that Ciitizen was acquired in 2021 by Invitae, which is a medical genetics company. So you often see the logos and the names of these two companies together. Okay, so when you join the digital natural history study, you get access to a parent portal. And I participated in this study, so I'm going to show you what my parent portal looks like. So here is the home view of the dashboard. And from here, I can access all of Chelsea's records, my daughter, by clicking either on your documents or in the upper right-hand corner by clicking on my records. And when I do that, I see a long list of Chelsea's records. Here you see just the first 10 records that show up. But if I click on any one of these, I'm going to get all of the details that accompany that particular record. The records also include all of the imaging reports. So here you'll see X-rays, ultrasounds, MRIs, and more. Now, last week, I took Chelsea to see her massage therapist, and she mentioned to me, I wonder what Chelsea's x-rays looked like before she started coming to me. And I pulled out my phone and I said, well, you don't have to wonder. I can show you right now what her x-rays look like. And I was able to do it right on her phone, right on my phone. Now let's go back to the home screen. And this time, let's click right here on the disease summary report. So now you're seeing a screenshot of just the first 4 features that appear. It's a really long, long list. And it's a combination of skills and abilities that were reported in her medical records, as well as particular symptoms. Now, for the sake of an example, I'm going to show you what you see when I pick a particular symptom, which in this case, I'm going to pick chronic cough. So if you click on chronic cough, you'll see all of the records where chronic cough is mentioned in the notes. And of course, I can click on any one of these and actually get all the details. And I can also see the medications that were prescribed for this particular symptom. If I click on manage, which is in the upper right-hand corner, this is where I am able to share records with anyone by just using, click of the mouse, or request records if you've been to the doctor or the hospital recently and you want to update your records. And if you have any medical records at home, you can also upload them yourselves. Right here, you'll see this upload document. Now, I had a big stack of paper reports and labs from when Chelsea was little, which were too old to have been in her digital record. So I was able to upload all of that paperwork. And so that is all now part of her permanent record that I have access to on this portal. Now, I think you can all appreciate the benefits of having access to medical records in one place, that you can view yourself, that you can share, and that you can search by keywords. I know of a mom who was in the emergency room with her child and was able to provide critical information because she was able to quickly pull up the records from a procedure that her child had done at another institution, and those records were not available to the ER doctors. I was able to see doctor notes from a long and rather traumatic hospitalization that Chelsea had several years ago, notes that I didn't even know existed until I had access to them through this portal. Importantly, you can choose whether you want to share your child's anonymized records with the clinical community, the research community, and biopharmaceutical communities. If you decide to share, and I hope you do, it's a painless but very critical way to advance research. Now, for those of you who have already participated in the digital natural history pilot study, make sure you visit your parent portal and explore your child's records. Now, I view the digital natural history study as a way to let valuable information not languish in our children's medical records, but put that information to work for your child and for the entire Rett community. And what we learn from the aggregated medical records could help us all. I'll give you an example. My daughter was having lots of pneumonias and was in and out of the hospital for a number of years. Her pulmonologist started her on a respiratory protocol, which included various inhaled medications and an airway clearance vest, which, as some of you know, is a very expensive piece of equipment that shakes the mucus in her lungs. Now, the medical records clearly show Chelsea's vast improvement in respiratory health since this protocol started 2 years ago. Knock on wood, she hasn't had a single pneumonia or hospitalization. This is the kind of important information that we can learn from a study like this, that we can provide families with documentation for insurance companies so that they'll cover this type of expensive equipment, and to share with our local physicians who may not be as familiar with Rett syndrome as our Rett experts are. A digital natural history study can also inform disease progression over time, help improve clinical trial design and execution, and in so doing, speed up the time that it takes to get treatments to our children. An additional goal is to be able to use the digital natural history study in combination with our registry information in regulatory filings to the FDA, either in lieu of a placebo group or in lieu of having to do multiple clinical trials. Now, there is recent precedent with last month's FDA approval of a drug for Friedreich's ataxia that used natural history study data in lieu of a second trial. And last September, a biotech company called Praxis Precision Medicine used their digital natural history study that they did with Citizen as part of their investigational new drug IND package. In fact, it was the first instance of a patient-mediated medical record platform being utilized as the primary natural history study data source for a successful IND filing with the FDA. These are tangible examples of patients taking control of their records and expediting drug development. Now, Dr. Fu and Dr. Suter will share some of the data that we've already gathered, and you'll see that it reconciles very nicely with the traditional natural history study, which is pretty wonderful considering it was just a pilot study of 119 individuals. But there is power in numbers, and so I'm hoping that many of you listening today will join our efforts. And here's how you can do that. Here's the URL right here at the top of where you can visit and join the study. There's a QR code so you can scan it and find it easily. This is what the website looks like, so you know you're in the right place. Know that to join, you will need a driver's license or other form of ID. You'll need your child's birth certificate. And if your child is over 18, you will need guardianship papers. For now, the digital natural history study is restricted to the US only, and that has to do with the legal requirements for accessing medical records. As I've said before, there is power in numbers. So I really hope that you'll join and that you'll share with other Rett families so together we can grow this very valuable resource. And now I am going to turn the presentation over to our data scientist, Kristina. Oops, sorry about that. Okay.
It's all right. Hello, everyone. I'm very happy to be here with the Rett Syndrome Research Trust. We kind of bumped into each other by serendipity as I was looking into Citizen as an option for the community that I serve primarily, which is the Cast Gene Foundation. But I hold the Rett community very close to my heart, as there are a lot of similarities between the two populations. And there was actually several years when I thought my own daughter might have had Rett syndrome. So I really love what I've been able to accomplish with this. I want to tell you a little bit about how the data gets from the records to us so that you can have a better understanding of what that process entails and how your child's privacy is protected along the way. So after the records are collected using your consent forms, the first process is to extract and code the data. That is done initially through machine learning. They have some pretty impressive algorithms that will scan through the documents for specific phrases and words that it's targeting based on the disease model that they're looking for, and they pull those terms out. You can see those terms being identified by these blue boxes around the text that's coming directly from the written report. But as you guys probably know from seeing multiple different clinicians and offices, a lot of times different doctors will phrase things different ways. And so it can be hard to compare different records strictly apples for apples if you take the verbiage exactly as it's written in the report. So what they do is they normalize it. So they create a second data set that shows what they would refer to that text as in order to compare it equally across records. So you can see this example here where it says decreased tone throughout. They normalize that to say generalized hypertonia. And they do that with other similar phrases so that we can compare multiple records for the same child or records from different children in that apples to apples way. Then after they've normalized the terms, they code it. And that's what you can see with these numbers here. There are a variety of standardized databases that are used throughout the research and pharmaceutical industry where they've gone further to map these basic terms that they've chosen to make the common reference for that, and a number that then ties that to several other levels of information. So we might know that the decreased tone throughout, which is normalized to say generalized hypotonia, refers to muscle tone as a category, and that can be associated with neurological examinations as an event. Moving forward, the next step is how that data comes to the Rett Syndrome Research Trust. And this is a bit of an example, just for clarification. This is an actual patient ID from the study, but I've included it with data from a different patient. So I'm double blinding this one that way. But what you can see is we don't receive the name of the patient. all of their direct identifying information is replaced. So instead of a name, we have an ID number. Instead of a full date of birth, we'll have maybe just the year or their age at a particular event. You can see in this top example, the blue fields here are what come from the demographics table. And then we can pair that with the primary diagnosis table, which in this case is Rett syndrome, by matching that patient ID. Taking it a step further, in the gray, you can see that this is another table that they give us that is other clinical diagnoses. So they might have been diagnosed with other secondary things in addition to Rett syndrome. And by matching the patient IDs, we can match the clinical diagnosis to that original patient. Moving down to the line on the bottom, you can see again in the blue, we've got the basic information that comes from the demographics. And in this example, I've matched the patient IDs to collect or to relate their seizure records. So here's an example of 9 different lines where the machine learning was able to identify that a seizure or seizure event was recorded, and that pairs it with their age when that was recorded and the number and frequency for those seizures. So this is kind of how it comes to us in there. So at this point, as I'm receiving the data, I am not able to identify any patients. I then take those data tables and plug them into a data analysis program. In this case, we're using a program called Tableau, which is an extremely powerful data analysis program. It is able to do all of that data relating for us to match patient ID from one table to patient ID to another table. And we could relate, 10 or more tables all together for the same set of patients, and it would be able to correctly compare and analyze the information for all of these different patients as a group and give us some interesting statistical information about it. So it becomes more than just data lines, it becomes useful informatics that we can use for all those wonderful purposes that Monica mentioned. And on that, I'm going to go ahead and turn the time over to our clinicians, where Dr. Fu can start showing you the very, very preliminary results that we were able to pull from that data analysis.
Thank you, Kristina. Yeah, it's definitely a pleasure to get to be here today, and it's been a privilege to be part of this very exciting project. So we've heard a little bit about kind of the overarching goals of this project, and kind of we've learned about citizens' capacity for collecting and collating this data that families will be contributing, and then we've heard from Kristina about how this data is going to be analyzed. So let's talk a little bit now about how the data that we've gotten out so far from these first 100 or so families that have, we're very grateful for their contributions thus far. And I think it's important to remember as we go through this data that this is very preliminary, and we view this as pilot data really to help us better validate, because this is a very cutting edge method that Citizen uses. And so I think in order to validate the veracity of this data, we're going to be kind of comparing to what we already know, a lot of this background from observational studies that have been previously done, from the natural history study data, areas that we can be confident about, and then areas that we might, need to troubleshoot a little bit more. And so again, this is a work in progress, but I think what we can definitely say that everything we've seen so far is very encouraging. All right, so this is an example, this first slide here, of what has been contributed so far. And you can got to get a sense of citizens' capacity for collecting data from multiple sources. So you can see the majority of individuals, of families, have contributed at least a decade's worth of data, if not 2 decades. And a lot of these predate digital records, digital record keeping. And so you can see that whether it's paper-based records or modern digital records, Citizen has the ability to compile it, collate it, and allow us to make use and analyze it. And so, again, I think this speaks to the capabilities of this platform, which is very exciting. And here we can see this next slide, again, initial verification of what to expect. And again, the vast majority of the individuals that have contributed data with MECP2 mutations are girls, are women. with MECP2 mutations, most likely diagnosed with Rett syndrome. And then, as we would expect from just the general population, a very small number of males that have MECP2 mutations contributing. And again, this is very similar to what we expect from prior observational cohorts. All right, so that's, again, a good verification of the validity of our data. We see a very wide age spectrum, and so this is just a histogram showing at the time of diagnosis, not at the time of data contribution, but at the time of their Rett syndrome diagnosis, how old they were, and then the current age at which time the data has been contributed. And you see, as we would expect, most of these individuals were given the diagnosis by the age of 4, which is really what we would expect. Most people diagnosed with Rett syndrome would be manifesting the core clinical features by that age. And then some of the older individuals very likely predated our knowledge of the MECP2 gene. And so some of these may have manifested symptoms much earlier, but they weren't given that formal diagnosis until somebody decided to actually test them for a mutation, in which case it results in the official diagnosis be given later, and so that may explain some of those older individuals. But again, this speaks to the capacity of Ciitizen to kind of collate this historical data from these individuals, because you can see the average age of people at the time of data contribution is around 18, and so again, this is very much mirroring kind of the age ranges, age groups that we saw in the natural history study. All right. And again, this slide here, looking at the percentages of the different MECP2 mutations that are leading to their diagnosis. And again, this is very much mirroring what we expect from the greater population of individuals diagnosed with Rett syndrome in this country, primarily based on prior observational studies, publications, the Rett syndrome natural history study. We know that roughly 60 to 70% of individuals will have mutations falling either in the missense category or nonsense category, as you see here. And you can see on the left, again, with the colors, those are the general categories of the type of mutation, and then there's a few specific examples of actual patient mutations that are part of this database. And all the more common mutations are definitely represented here. And so again, I think this shows us that the people, even with just this first 100, it's very much representative of the greater population. All right, so moving on a little bit more towards, so that's data we have about age ranges and mutations. Now, what about symptoms? We know that Rett syndrome has many medical comorbidities, and so we've listed here histograms of individuals with the most common indications requiring symptom management. And this is really what we would expect based on a recent publication looking at these, the different medical comorbidities that arise in the setting of Rett syndrome. You see, I think a lot of families will appreciate this. Constipation, a lot of these is a major component of the gastrointestinal manifestations of Rett syndrome. And so the vast majority of individuals are on a medication for constipation. And again, rounding out the top 5, epilepsy, we also know is one of the more common comorbidities in Rett syndrome. Other GI disorders, sleep irregularity, and then the mood irregularity. So again, those are the top 5. And this is, again, very much based on, or very much mirroring, what we would expect from prior reports. So again, it's very encouraging. And with regards to the actual medications that are used, these can also be derived from the data set that's collated. So the most common ones, so polyethylene glycol or Miralax, right? So very, very common stool softener that's used to combat the issues with constipation. And then below that, you can see, again, managing those top 5 most common comorbidities. So diazepam, that would be used as rescue medication for seizures in the setting of epilepsy. Levetiracetam, so the most common anti-seizure medication that's prescribed for individuals, with epilepsy. Then we have melatonin for help with falling asleep, and then another anti-seizure medication, valproic acid, which also is very good for mood stabilization. And so, again, this is also very consistent with what we saw in the natural history study with regards to the most common medications prescribed, because as all the families online are well aware, up till recently there was nothing specific for Rett syndrome. It's really just a lot of these symptoms are managed based on how based on the general population and kind of the medications that are available for managing symptom management in the general population. And so this is just for common routine medical practice. These are the most common medications that are used. All right, with regards to epilepsy, again, one of the most common comorbidities that we see. This is data showing the percentage of individuals in this cohort of this first cohort of 100 that have an active diagnosis of epilepsy. And this is, again, very consistent with what we expect historically, about 80% of individuals. And again, these keep in mind, this is a wide age range, and so it's possible that some of these individuals have yet to develop it, because a lot of times it's not, the epilepsy does not arise in Rett syndrome until after 4 or 5 years old. So some of the younger kids may not have, but in general, when you look at a static cohort, this is kind of what we expect, the prevalence of about 80% individuals have active epilepsy. All right, so again, good validation and encouraging in terms of the utility of this of the platform. Here is a breakdown of the different seizure types that we can expect in the individuals that have been diagnosed with epilepsy, and this is where we feel like we may need to go in and maybe troubleshoot some issues. So you can see this is what we would expect, is that pretty much all the different seizure types can be seen in Rett syndrome related epilepsy, but there are some areas where probably the numbers are a little bit lower than we would expect, such as the tonic seizures. I would actually expect historically to see more of that in individuals who have Rett syndrome related epilepsy. And part of this is just, I think, is going to be dependent on data documentation, clinical documentation, and depending on the experience level of the clinician who's documenting. They may not necessarily document the very specific type of seizure, and they may just call it either a focal seizure or a generalized seizure, which is more generic and maybe broad-based. But sometimes generalized seizures are tonic, sometimes generalized seizures are atonic, but they may not go into the nuts and bolts of things. But again, this is an area where this is preliminary data, and I think further troubleshooting will help work this out. But it's also, I think, an important thing to note, to hopefully encourage families to contribute their own data in the World Registry moving forward, prospective data that can help kind of shore up some of these areas that maybe we're seeing some unexpected findings right now. And again, I think the prolonged seizures, I think we can find to be, this is usually very reliable in terms of documentation. And again, it's good to see that this is kind of consistent. What we expect is that even though children who have Rett syndrome, who have epilepsy, sometimes they can have frequent seizures, but by and large, those seizures are short. And so you see a minority of this cohort actually have documented, prolonged seizures. All right, as far as how we manage these seizures, I think this is a histogram showing the total number of anti-seizure medications that have been prescribed over time, just to kind of give a sense of the complexity of the epilepsy and the difficulty in getting seizures under control. So this is not total medications at any one given time. That would be a lot. Nobody's going to be on 17 medications at once, but it's possible that in individuals with more challenging to manage epilepsies, you can end up cycling through lots of different anti-seizure medications. And so on average, about 5 medications are tried for a given individual, but you can see most of the individuals are under that, 6 and less, which again reflects what we would kind of expect for the overall population, where most people can have their seizures get under relatively good, if not complete control, after a third medication, and it's just a minority that end up having to cycle through a significant number. As to the specific seizure medications that are prescribed, again, this is very much reflects just routine practice in child neurology and in pediatric epilepsy, and so not really Rett syndrome specific, but again, just as we would expect, and this is mirroring data that came out of the natural history study, where the top 5 medications are really levetiracetam, valproic acid, oxcarbazepine, lamotrigine, and topiramate. In roughly those numbers, relative percentages, and again, you can see where some of the newer medications towards the bottom, like perampanel, lacosamide, and rufinamide, are not as heavily represented, not so much that because they're any less useful, but just because they're newer, and we tend to start with the older medications first, because the newer medicines don't actually work any better than the older ones, they're just different. But again, this is very much consistent with what we expect from routine practice. And again, you can see at the bottom the difference in rescue medications, where diazepam is by far the most commonly used, which is often in the form of rectal diazepam or diastat. And the data captured doesn't distinguish between whether it's rectal or nasal, but there was recently introduced a commercial version of a nasal rescue diazepam, which, if we dug in deeper, we may see that as we move forward, since this has only been 3 years, as we move forward, we'll see probably more and more nasal diazepam being prescribed in the coming years. Okay. All right. So that ends my section of the data presentation. I'm going to hand it over to my colleague, Dr. Suter, to talk about a little bit more about the rest of the data that we've been able to analyze thus far, that Kristina's been able to analyze. Dr. Suter, take it away.
Well, thank you very much, and hello, everyone. And whoops, did I flip that already? I want to go over some data that we extracted, some nice insights on development from this pilot data set. And what you can see here is really also a reflection of roughly what we would expect in this population, with a large majority of individuals achieving sitting unsupported, and maybe about 2/3 of the population even eventually walking, with or without assistance. However, a much smaller number achieved the ability to run or jump in place, as we would expect. If we look at fine motor function, again, you can see that pincer grasp, for instance, is achieved by less individuals than, obviously, individuals that reach and grasp. Okay, And if we then come to the communication domain, language and academic development, you find very nicely portrayed that most individuals can use some form of nonverbal communication, which also will include meaningful eye gaze, reciprocity with their caregivers. And there's a really significant proportion that achieve a single word versus individuals that are much, much less frequently found that are able to use a short phrase or use sentences even, though that is a skill that is also achieved in this population at times. If we make a jump from development and look at other comorbidities and then the use of orthotics and assistive devices, we find in our pilot data set an ample support of people who use AFOs by a large distance more frequently than other orthotics. And I think that is something that we see in clinic quite clearly, that ankle foot orthoses are very, very common in this population to counteract stability problems and naturally occurring increases in tone. In a significant proportion also is using a wheelchair, now potentially not solely for mobility, but to aid in transport and transfers, etc. And on the communication side, you can see that assistive devices are not uncommon at all, and higher tech communication devices, augmentative communication devices are actually quite frequently used, more frequently than more simple choices, such as a communication board and or a PEX communication system. Moving on to more severe, let's say, issues such as reasons for hospital admissions, we recognize on this slide that in terms of planned admissions, a large majority centers around, not surprisingly, the workup of seizures. We had Cary, Dr. Fu had already mentioned how omnipresent that problem is in this population. And so epilepsy monitoring unit admissions feature very, very prominently in this population. If you look at more unplanned admissions, certainly there are those for seizures, but then the next big group will be obviously admissions for intercurrent illnesses, predominantly respiratory illnesses and pneumonias, which I think fits our understanding quite nicely. If you take a step further and look at planned surgeries and what you see reflected here amongst our 113 patients is that GI problems obviously feature very, very prominently in this population. And unfortunately, nutritional issues can get so severe for various reasons, including feeding and swallowing issues, etc., that a high percentage of participants actually has a G2 place. This is maybe a little bit higher than we would have expected at the baseline, but it speaks to the fact that we are capturing this signal very nicely in this database, and we just need more data to refine the absolute percentages. And another extremely common comorbidity over lifetime in Rett syndrome, occurring in like 80 or 85% of over 16-year-olds, is scoliosis. And you can see in our data set, we already come close to that prior number that I just quoted out of the natural history study and other studies, with 64% having scoliosis. And a large percentage of those with age may actually need surgical correction, similar to G-button placement for the GI issues. And this, again, is not surprising data at all. It is very concordant what our experience is in Rett syndrome. And finally, one aspect that we could already tease out in terms of female development is that we could replicate that that individuals with Rett syndrome tend to potentially enter puberty early, but menarche is a little bit delayed, here at a mean of 12.5 years of age, which prior publications have included ages such as 13. So we're coming really very accurately close to that figure as well. And with that, I will hand it back over to Jana to provide a wrap up.
Thank you, Dr. Suter. So thank you, everyone. I'd just like to kick off our conclusions by thanking the 119 parents who have contributed to this amazing data set so far. Thank you so much. Some of I think the biggest overarching conclusion that we can make is that this data has been highly representative, not in every case, but there are a lot of wonderful signals that we're able to pull out of this unbiased data set that support other findings that have already been found and really establish the validity of this data set and show how valuable it can be. Now, our goal is to really share information back with parents, things that are going to be useful, help you with your day-to-day care. And so I'm excited as a scientist and as a clinical researcher to actually be able to give you some conclusions that you may be able to take home from this data set today. So the most common non-seizure medications that are prescribed are polyethylene glycol or over-the-counter Miralax for constipation and melatonin for sleep that Dr. Fu showed us. The most prescribed anti-epileptic drugs are levetiracetam, valproate or valproic acid, and diazepam as the rescue medication, which we also discussed. In terms of hospitalizations, about half of all hospitalizations are planned, which is great. In terms of unplanned hospitalizations, those are due mostly to seizures and respiratory issues. From a surgeries perspective, about half of participants in this data set have had surgeries for feeding tube, and about 40% have received surgery for scoliosis. And we were able to replicate, as Dr. Suter mentioned, that periods tend to start around 12.5 years of age, which is unique to the Rett syndrome population. Now, just like any data set, there are also limitations to this study, and some of them are listed here. Now, the data summaries, as Dr. Fu mentioned, are only going to be as good as the detail recorded, and that's going to be based on the type of physician or clinician that's recording information in the medical record, what their focus is, what their specialty is, and of course, how carefully they document their findings. This data set can also suffer from inconsistent data recording. So unlike a traditional natural history study where you're directing data collection in the same way across every single patient, that makes it really easy to generalize information very broadly. But in this particular study, we're collecting whatever data is available. And so that can lead to spotty data collection in some cases. And as we all know, if anyone's had the opportunity to review your own medical records or those of your children, they're sometimes inaccurate. Right. So, there's definitely times where a medication may be prescribed, but the pharmacy never fills it and things like that. So they may not be totally representative in every case. But as there are also solutions to these limitations as well. And the best thing that we can do is really increase the cohort size. So the more patients that participate in this study, those anomalies in the data set, they quiet down, and we start to get a much more representative data set the larger that it grows. And the other thing that we can do is to have participants participate in multiple studies. So if you're participating in our Citizen Digital Natural History Study, it would be great to also participate in our parent-reported Rett Syndrome Global Registry and other studies. So then we can also start to correlate differences between the data sets and start to generate really deep data sets on a subset of patients. So just to conclude, I want to show you where we've been today. We have finally learned how to tap into this untapped resource of medical records, and we're utilizing them now in the digital natural history study, and we're contributing to research for Rett syndrome. And that's the data that we have summarized and presented back to you today. And in a future webinar, we will also review the preliminary results from the Rett Syndrome Global Registry from our pioneers that have been working really hard to help us generate a foundational data set in that database, and so we'll be presenting that later as well. Now, before I switch over to our question and answer session, I just want to quickly show the URL for the Citizen Digital Natural History Study. I encourage everyone to please join if you're not already participating. And here again is the QR code if you'd like to scan it. All right, so I'm going to stop sharing for just a second so we can get our panel up to start addressing questions. Okay. Am I still sharing my screen?
Yep, still up there. There we go.
There we go. Okay. Hi, everyone. So I think we can go ahead and try to take some questions here. Let's see. Okay, so I have one here from one of our audience participants. What should we do about errors in the record, as well as wrong or poor medical care decisions? So I think this should go to either Dr. Fu or Dr. Suter. Do you have any recommendations?
I actually would like to bounce the question back because I'm not sure, is this pertaining to this database? Let's say a parent finds an error in the medical record and enters this into the database, or is the question pertaining to correcting it in the database or contacting the physician simply, the original physician? For healthcare, obviously, turn back to the originator of that record, of course.
Yeah, and definitely, I agree. Is that we encourage all families to kind of verify their child's medical records, and we shouldn't have to do that. But if you see an inconsistency, and I've had my own patients come back to me before, not with Rett, but with other things where they've brought up, this is surprising. I was not surprising to see this in this note. Can you provide clarification? But physicians would be responsive to that. And so we would encourage you, if you see an inconsistency, to bring it up with the treating physician. But remember, so these records will all be anonymized. So we, on this end, will not see who these belong to. So it won't be something that can be rectified on our end. And so it'll be important that, and again, this will be important for us too, because if you see something that's not valid, maybe before, submitting it, make sure to have that corrected. But again, that speaks to the importance of participating in multiple studies, and also then, in the future, also contributing data to the global registry, which can then help to maybe rectify some of that, because when you can, kind of marry that data from parent contributed, and then medical record contributed, it tends to be, we believe that there's no individual that knows their child better than the parents. And so that would be kind of a further validation, verification of the veracity of the medical record. So, yes.
Great, thank you.
And
all right.
If I might add to that, there is also some amount of checks that come into play in the analysis process as well. Whenever we're looking at the information, we do kind of do kind of a common sense check. We see what those stats are. You saw those tables with the mean, median, average, standard deviation. And if there are outliers that are just so far outside of that range of what might be expected based on the data set, we do look at them a lot more closely. One example might have been, at one point we came across a line that showed that someone had a deletion of exon 5 on MECP2. And for those of you that know the gene, you know that it's only a 4 exon gene. So we were actually able to go back to Ciitizen and challenge that data line and say, hey, is this actually what's written in the record? And they were able to look at the record and see it did indeed say deletion of exon 5. And beyond that, they were able to then contact the family because they do know the identities. They were able to contact the family and ask them for more detail about it. So there are some safeguards and checks throughout that process as well.
Great, thank you. All right, so I have another question here. If the patient does not have an MECP2 mutation, but has a diagnosis of a variant of Rett, are they able to join? And I'd like to take this one first, and then I'll hand it off to the rest of my team here. I would say please join, because we're able to filter different data sets based on an MECP2 mutation or not, or whatever. And the more information we have, the better. In the Rett Syndrome Global Registry, which is the parent-reported data set, we're also doing that same thing. So my preference as the scientist would be, let's get as much data as we can, and then we can appropriately filter the data down to the right categories depending on what the question being addressed is. So I would say if you have an MECP2 mutation but not a diagnosis of Rett syndrome, please join. If you have a diagnosis of Rett syndrome and no MECP2 mutation, please join. So we can filter all of that stuff out as we go through. I don't know if you guys have other thoughts on that you'd like to share, but please go ahead. Okay. Let's move on. So here's one more. How are the symptoms and comorbidities tracked as they change over time? In other words, will the data show changes, good and bad, as the girls change? So I think, Kristina, you know the answer to this best. So why don't you start?
Yeah, in the data set for the other comorbid diagnoses, we actually get two different table sets. One of them just shows the date that they were given a particular, or not the date, but what age they were in days at the time they got a particular diagnosis. But then there's a secondary table that shows if there's any other related data to those clinical diagnoses. And so that'll show if they noted, is it improving, is it worsening, is it staying the same, which we haven't yet put into any data visualizations, but they do actually pull that aspect out of the records with their machine learning as well.
Anyone else want to add? Okay. Just to answer quickly, someone asked if we're collecting data post-mortem. We are. So you can go ahead and contribute your loved one's records if you'd like. One other question. How is the digital natural history study being funded, and for how long? And will this be dependent on future grants? Monica?
RSRT funded the initial pilot study. Ciitizen is now themselves funding the next 1,000 patients from any type of seizure-related disorder that we recruit. So anyone that's being recruited now that has Rett syndrome, Ciitizen is actually picking up the tab for that. So that's a great time to to hop in and participate.
Let's take another question here. Here's one. Is there anything we found through the analysis of the data that surprised us, or a signal that we didn't otherwise think existed? I think this should go to Dr. Fu or Dr. Suter.
From my part, what I would comment is that we're still at a stage where we're really looking at the data to relate it to what is known out there in the field. So we have not yet really dug deep into, surprising findings. I think surprising, the largest finding here is that we are obviously not exactly on the mark with our numbers from what we know before. So I think a larger data set is so direly needed to improve on these frequencies and really tease out what is surprising, what is not surprising. Cary, any ideas?
Sorry, I lost my lost my unmute. No, I think that's absolutely right, Bernhard. It's, again, this is very much, we're in the preliminary stages, and I think there's so much more work for Kristina to do, but really it's all about kind of verification right now. So nothing earth-shattering, surprising. We're seeing where there are some gaps right now, and so we're going to work on how to kind of shore up those gaps to really start doing more substantive analysis. So right now, again, we're just trying to verify that this is going to be a usable, useful data set, and then how best to utilize it. But it's very encouraging thus far, and it's very exciting to be part of it, to see kind of how we build from what we have thus far.
Jana, if I might add as well, one specific example that we discussed this week was the findings that came up when we were looking to find medical record evidence of a developmental regression, where we found we didn't see that in all of the patients, where you might expect, because the clinical diagnosis of Rett syndrome does require that they've had developmental regression of some time. So it led to more questions and more discussions about the difference between whether or not the record sets are incomplete because doctors might not be asking about the developmental milestones after a certain age, or perhaps we just are getting new diagnoses of babies who are being diagnosed straight from their genetic testing, and they haven't yet had the opportunity to develop to a point where they could experience a regression. So there were definitely some oddities that we found, but nothing that is concrete enough to say that this is the truth about Rett syndrome, rather than what is the question that we need to be asking.
Great, thank you for that. That was an excellent addition. All right, another question we have here: will we be able to query the database ourselves, like symptoms based on mutation types? So I think the answer to that for the citizen database is no, that individuals can't query and look at the overall results. We can do that for the Rett Syndrome Global Registry. So you can go in and you will be able to see overall, the prevalence of different symptoms, medications that are used, that kind of thing. Our plan, though, is to share data back with families at regular intervals. So if there are specific questions that you're interested in, you can send them over and we can take a look at that. So we're all about trying to help you care for your child on a day-to-day basis. So please help us do that the best way that can help you. Monica, do you want to add anything?
No, I would just say to watch for an announcement regarding the global registry. We're close to launching.
All right, I think there's one more quick question we can take here. When we referred to the MECP2 mutation slide, did we include both duplications and deletions? So we did include some deletions. We didn't include MECP2 duplication syndrome, so not an overall duplication of the gene, but if there were regions of the gene that were duplicated or insertions, those types of things, those were included. All right, so I think with that, we are 3 minutes over 5 o'clock here on Eastern time. So thank you very much for joining. Again, a very special thank you to, yes.
So sorry to cut in.
No, please.
For the last question that is still there, can we refer her to look and search for her nearest Rett Center and contact her nearest Rett Center for the question that is still up there?
Sure.
I'm going to put my email in the chat. I don't want to say the person's name, but nope, you know who you are. So if you want to contact me, I will try to help you out.
Thank you so much.
Put my name in the chat.
Yeah, I was thinking we could email her. But just to close the session today, I want to thank everyone for joining today, especially the families who participated in this study and made this presentation possible. Thank you so much for taking the time to do that. I also want to thank our guest speakers today, Dr. Fu and Dr. Suter. It's been such a pleasure working with you and trying to understand this data, and we're looking forward to getting a publication out of this and continue to see what we can learn. And of course, to Kristina, our data scientist, who has been instrumental in us understanding what these data mean. So thank you all so much for joining us today, and please sign up if you're not already involved. Have a wonderful day.
Thank you, everybody.
Thank you.
Bye.
Take care.
Bye now.